In the meantime, can I call my faculty, Dr. Ritu Arora, Dr. Sujata Mohan, Dr. Kuresh Maskati, Dr. Vavikar, to come and join us in the... So today we're going to talk about fighting the bulge. As you know that bulge nowadays, whether it's in the abdominal bulge or maybe even any other bulges, are something which is not something to look forward to. And so goes the bulges on the cornea. So we have an array of speakers today. So we'll start off with the diagnosis of keratoconus. To talk about the newer investigative modalities, topography and the anterior segment OCT, we have Dr. Ritu Arora. Following that, Dr. Vavikar would talk about the recent advances in corneal collagen cross-linking. We'll then be discussing combining topography-guided surface ablation with cross-linking. Dr. Sujata Mohan will talk about the intracorneal rings and cares. Dr. Rajesh Fogla, who will join us soon, will then take us through his journey of DALC for cases which have progressed beyond a particular point. And Dr. Kuresh Maskati will then tell us what is the toughest part is always at the end, how to manage the residual refractive errors in KC. So I first call upon Dr. Ritu Arora to talk to us about the newer investigative techniques.
C-type? Connector.
Hello, yeah. I know it's lunchtime and yeah, it's a pretty warm hall, but we're also talking about a very hot topic. So at the outset, I'd like to thank Dr. Nitin, who's been a good friend and a fellow marathoner. And I'll be talking about some of the newer investigative modalities, more specifically the tomography and ASOCT. Now, as we know that keratoconus has been classically defined as a progressive non-inflammatory thinning disorder of the cornea, which leads to ectasia and a disturbed vision, though we know that inflammatory factors are also important. And we also know it's bilateral, asymmetric. It has a increased prevalence, especially in our South Asian and Middle Eastern populations, with a strong association with allergy, atopy, eye rubbing, contact lens use and all. So it usually presents in puberty in the late teens and peaks in the second and third decades. But now in this era where we are doing more and more of refractive surgery and we have newer modalities which my fellow speakers will be talking about, so we need to diagnose keratoconus early. I will not delve into the pathophysiology, though we know about the abnormal collagenase activity and some of the markers and inflammatory markers, which the genetic factors, the environmental factors, they all get together, which lead to biomechanical changes and resulting in keratoconus. So the two hallmarks are thinning and ectasia. But when do we diagnose it? Clinically, we know some of the features, but I'll be focusing today on some of the investigative modalities. Now, these clinical features of established keratoconus, we've all been very familiar with in our undergraduate days, postgraduate days. And it's not that we always see these cases at an advanced stage. I think it's becoming a little less. But what we need to do is diagnose it as early as possible. So one of the important diagnostic modalities that we have has been the topography. We know about the Placido disc, the video keratoscopy, but this has been, it has stood the test of time. It's been there since the 19th century. But we know it images only the anterior surface. And we know that keratoconus actually starts from the posterior surface. So the slit scanning, which came out with the OpScan, which came out, that was the first instrument that was able to measure the posterior surface. Now, of course, we have the Scheimpflug imaging systems, various modalities. I'm more familiar with the pentacam, and that's what I'll be talking about. So what do we look for on the tomography? There are various parameters, shapes, maps, and for a novice, it can be quite, confusing. The important thing is to identify that the patient demographic data has been correctly entered, because birth date is important, because the parameters are, compared to the normative data. So after you've confirmed that the patient data has been correctly entered, the next thing that we need to look at is the quality specification. Has the scan been done correctly? Now, once you've seen this quality specification to be okay, then you can go ahead and say that this scan is reliable, and you can further, delve into it. So just below the quality specification, you have the Q value, and we know that normally the cornea is prolate, but in cases of keratoconus, you have a hyperprolate cornea. And what I do is, after I've seen these two parameters, I come straight down to the Kmax and see what is the maximum keratometry. If it is above 47, it's already a red flag. But again, one needs to be cautious that not every K reading which is within the normal parameters is actually normal. So that should not, keep you in a comfort zone that just because the Kmax is normal, that this is a normal reading. You need to look at the inter-eye asymmetry. You need to look at what is the Kmax and the steep K. Is there a difference between the two? And you also need to look at the astigmatism. If there's a difference between your manifest and your topographic cylinder, that again is a red flag. You need to rule out, of course, that the scan has not misaligned, because or the dry eye or the patient has not already been putting some dilating drops and then you've taken the scan, because these can be fallacies. The next thing I look at is the thinness pachymetry. And we know that if anything which is less than 500, especially less than 470, again, that is considered to be abnormal. Now, one important thing is you need to look at the thinnest location. So the thinnest location, the Y coordinate, is it displaced? If it is displaced, the Y coordinate, if it is inferior, again more than 0.5 mm, then again that is a red flag. So after you've seen these particular things, then you go on to the 4 maps. And in the 4 maps, you first look at the sagittal curvature map. We've been familiar with the different shapes. We know that the shape can be either symmetrical, asymmetrical. You can have the skew or special shapes. But even what I would like to emphasize, that even a symmetrical shape, a round or oval or a symmetrical bow tie, can still be abnormal if the Kmax is increased. And some of the asymmetrical shapes can even be normal if you find that the superior-inferior difference is within normal limits, if the skewing is not there. So once you've looked at all these factors, the superior-inferior difference, the skewing of the radial axis, then again you can further think whether this sagittal curvature map is within normal or not. So this is a 22-year-old patient who presented with some disturbance in vision, and we found that his right eye had a high myopic astigmatism. We did his pentacam, and so here you can see the Kmax is more than 47, it's 57. There's an asymmetrical bow tie with an inferior steeping, and so this is a very obvious case of keratoconus. Now next you come is to the elevation or the anterior and posterior floats. Now again, over here first to look at the overall shape. Normally it's a central island or an hourglass shape, but sometimes you have these abnormal tongue-like extensions. Even though the otherwise all parameters may be normal, but if you have a tongue-like extension, again you should be cautious. And then you need to look at the thinnest location, the elevation, which in myopes it should be ideally less than 8 in the anterior surface and less than 18 on the posterior surface. So these parameters you need to, just maybe put them up near your pentacam so that when you're looking at it, you can easily identify, or your technician can easily identify and, red flag anything which is abnormal. So coming to the pachymetry, we've already seen the thinnest location pachymetry. Again, you look at the overall shape, whether it's concentric or whether you have any abnormal shape like a droplet or a dome or bell-shaped. And again, looking at the superior-inferior difference is important, and also comparing between the two eyes is important. Now we know about the best fit sphere, and the BAD display, the Bellin-Ambrosia enhanced ectasia display, has really helped to highlight those subtle changes which one may miss on a normal best fit sphere. So here the thinnest location area, which is 3.5 to 4 millimeters, around that is excluded, and you get an enhanced best fit sphere, and then you look at the difference between the two. So again, here you can see that whether it is coming within the green zone, that is less than 5 microns difference, or you're having a more high, greater than 7 micron difference between the two maps. Seeing the D values can be misguiding at times. You may get a yellow or a red, but you need to look into it, why, at what point, what parameter is abnormal in it. And only then can you, further look at whether these maps are normal or abnormal. So just one parameter is not sufficient. You have to look at all of them. So as I also mentioned, the inter-eye symmetry is important, and you can look at these various parameters between the two eyes to see whether there's a moderate risk or a high risk. So in summary, there are many parameters to be looked at, and only when you identify all of them can you come to some kind of a conclusion. But there are fallacies, as I said, the image quality, the patient fixation, tear film irregularities, whether the patient has been wearing contact lenses, whether there are any subtle scars that you may have missed. All of these can misguide or mislead you. So the newer kid is the epithelial mapping, which there are several articles about it, and Dr. Dan Reinstein has done stellar work in this regard. And basically what they have reported is that the keratoconic corneas, they tend to have a donut epithelial pattern, which is there's a compensatory thinning over the localized stromal surface over the cone, and the surrounding area is thicker. So they had used high frequency ultrasound, but now we all have OCTs which can help us to easily look at this. Normally the epithelium is 50 to 60 microns, but they're in the center. But there's a difference between the inferior, superior and temporal because of the eyelid mechanics and blinking. And in the keratoconic corneas, as I mentioned, there'll be a thinning over the cone and a thicker epithelium surrounding it. So basically the epithelium acts as a masking agent over any of the stromal irregularities. And this remodeling is a dynamic process. And this can help us actually to differentiate the formfras keratoconus from the true ectasias and also, pseudo-ectasias. So here we can see that basically keratoconus starts from the posterior surface. And by the time it comes to the anterior surface, the epithelium may act as a masking agent. So we look at the profile on our OCT along with doing the pentacam. So here you can see that you have a case where the epithelium is normal, and in cases where you have a subclinical keratoconus, you have some differences on the topographic map, and you can see corresponding changes also on the epithelium. The pachymetry at times may be normal, but when you see the epithelium, then you find out that the thinning is there. So this is another case where you can see that there is an inferior steepening, and you may think this is a case of keratoconus. But when you do the epithelial mapping, you find that the epithelium is actually thick. So this patient is a normal case. He may have been a contact lens user. He may be having, dry eyes, which may be actually causing a thicker epithelium, and that may present as a inferior steepening. So these patients can be candidates for LASIK, which you may otherwise reject. So we need to, avoid the false negatives. We need to avoid the false positives, so that those patients who are actually normal are not falsely labeled as, keratoconus suspects. So the future, biomechanics is another very, important aspect which we'll not be touching on today. But along with your topography, biomechanics has, now a very important role in identifying those cases who are vulnerable and maybe who need to be avoided as, candidates for refractive surgery. So the future would probably be of tier biomarkers and an increased role of artificial intelligence. But the importance of identifying these patients, whether your patient is a suitable candidate for refractive surgery, whether he's a keratoconus suspect, and whether you can intervene early in such cases and avoid more advanced keratoconus, that is the importance of adopting these technologies. Thank you so much.
Thank you, Ritu. I think in the interest of time, we'll take questions at the end of the session if it's okay. I now call upon Dr. Chandrasekhar Vavikar, who will be talking to us about recent advances in corneal collagen cross-linking.
Good afternoon, everybody, and thank you, Dr. Nitin, for giving me this opportunity. The first speaker, Dr. Ritu, has made my job easier. Now that we have established that diagnosis of keratoconus, we need to go ahead with the treatment, that is the universal treatment is corneal cross-linking. Now there are two types, chemical and physical. We are going to talk only about chemical, and in that also there are three varieties: enzymatic, glycosylation in diabetic patients, and oxidative, and we are going to concentrate on oxidative, that is the C3R. So ultraviolet A light activates the riboflavin molecule and it interacts with the oxygen to form bonds or the crosslinks between the cornea, thereby improving the strength of the cornea. What is the objective behind it? Primary objective is to improve the corneal strength and thereby halt the progression, whereas secondary objective is improvement in the quality of vision as well as corneal flattening. Now, corneal collagen, there are 2 points to remember: 8 years and 35 years. Entire cornea, the collagen is replenished every 8 years. So that is the time perhaps when we will think of patient requiring second treatment. Second point is that after the age of 35 years, naturally the collagen has become so stiff that patient won't require any cross-linking treatment. There are many protocols are available today, and let us try to make sense of them all. So the traditional protocol is Dresden protocol, where riboflavin is instilled on the cornea for about 30 minutes and then exposed to UV radiation of 3 milliwatts per centimeter square for 30 minutes, thereby giving a total surface dose of 5.4 joules per centimeter square. The limitation is that in this protocol the pachymetry has to be 400 at least, and there, of course, there are disadvantages and it has to be tackled properly. We were doing well with this protocol, and then we realized that there are some areas where there is scope for improvement. Number one is improving the efficacy, reducing the time required for treatment because it takes about 1 hour, improving the patient comfort, shortening the rehabilitation time, because previously we'll do C3R and we'll do rehabilitation after about 6 months, and that was quite some time. Improvement in quality and quantity of vision and solution for thin cornea. So let us look at one of these aspects one by one. So for decreasing time, we have accelerated protocols, whereby if you see that the irradiance has increased and the time has reduced, but the total of both is, the multiplication of both is 90. So it is 90 milliwatts per centimeter square. Either you give in 30 minutes for at 3 irradiance, or 30 milliwatts for 3. It was shown that till 9 or dose of 9 or 10 minutes is safe. But once you start going below that, what happens is that the results are not all that great. And that is because this cross-linking process requires a lot of oxygen, and the moment cross-linking starts, riboflavin attacks oxygen and there is nothing left, and therefore some time has to be given for the oxygen replenishment, and that is why we are come down to now maximum 10 minutes of reduction in time, not beyond that. The same was also established by Theo Seller, that there is a significant decrease in oxygen. Then reducing the patient comfort, increase the patient comfort. So when you do transepithelial, endothelial cells are damaged, mind you, when we are doing Dresden protocol, after 30 minutes we are ideally supposed to see the patient under slit lamp and see whether the riboflavin has entered the anterior chamber. That is because we want to protect endothelial cells. Transepithelial, we are trying to protect endothelial cells and increase patient comfort. But epithelium itself is a barrier for penetration of riboflavin and oxygen availability. So that's why the results have not been all that great. They were less effective. Okay, a randomized control trial showed that 23% of the eyes undergoing AP on treatment progress as compared to none with AP off eyes. Then we come to, so what is the solution? That we continue with AP on, but can we do something more? So one is the chemical enhancers. So there are so many molecules available, the important being tris, and what they do is that they loosen the tight interepithelial cellular junctions and therefore improve the penetration of the riboflavin. And indeed they have shown to be somewhat effective, but still long way to go from AP off treatment. Then we go to iontophoresis. Iontophoresis is nothing but electric current applied for the percolation of riboflavin. So first was to percolation of the oxygen, whereas the second thing is for percolation of riboflavin. Again, they were not shown to be all that effective. Then phonophoresis is there, where you are using acoustic cavitation, and oral riboflavin. Both are not very good because oral riboflavin has lot of toxicity. So how are we going to improve oxygen diffusion? In our normal Dresden protocol, there are two things which you can do. One is don't use any dry drops before surgery because they definitely hamper the penetration of riboflavin. Second, during UV irradiation, avoid putting riboflavin because that itself acts as a barrier for the UV light to penetrate. And in AP on condition, what we can do is that we can combine techniques. Number one is pulse ultraviolet A. That means the treatment is given for 8 minutes and 1 second on, 1 second off. So you are giving chance for the cornea, for the oxygen to be available again. Here for the first time we have shown that there is a significant improvement in the results, and the demarcation line also has shown little depth. Then you can have enhanced fluence, pulse, light and iontophoresis. So you are increasing the fluence, you are increasing the oxygen availability, and you are also increasing the riboflavin penetration. Again over here the demarcation line was at 285 microns, which is quite good. Then we can do oxygen supplementation. The demarcation line is at now 320 microns, which is quite good. Now we go to the next topic, is how to improve visual quality. I will come to these slides again. So for that what we do is photorefractive keratectomy or therapeutic keratectomy, PTK or PTRK. With this what we do is essentially we are smoothing the cornea, and both of them have shown that there is a significant increase in uncorrected visual acuity. Keratoconus is a contraindication for LASIK, and then how we are using excimer laser, but over here we are removing hardly 20 to 30 microns of the tissue. Then there is Keratoconus protocol where therapeutic PTK was done, a transepithelial PTK was done, and with the same result. Again the demarcation lines was shown to be quite low. Then there is some thing called as curve protocol. Unfortunately, I did not get much, and neither I have tried this. Then we go to thin cornea. So thin cornea, the simplest thing is using hypoosmolar oxygen riboflavin, so that the cornea swells and we can protect the endothelium. Then you can artificially increase the thickness of the cornea by using contact lens or epithelium island or lenticle, which we get with lenticle based refractive procedures. But the second last most important thing is pachymetry based accelerated CXL. Over here, all the factors were taken into consideration and a nomogram was developed. However, this is quite cumbersome. We require a lot of things, and therefore it is not that helpful. So what we come to is just follow Dresden protocol for sub 400, only reduce the time. And this seems to be working quite well, and 90% of the corneas where the thickness is less than 360, they are shown significant improvement. This is the protocol, everything is same. The only from Dresden, the only thing different is time. And this is the chart which shows on one side you can see the minimal stromal thickness, in between the time, and the last column shows the demarcation line. And it is also available as a calculator on this website. And now perhaps this is the most important slide of the discussion today, is that if you see, these are the demarcation lines which we develop with different types of treatments. So 320 to 350 is the Dresden protocol, and as you decrease or you play with the parameters, the demarcation line keeps on going down, up, and Apion is like the worst. So still we should stick to Dresden protocol only. PRK, LASIK and Smile Extra. I can take one more minute? Yeah, 1 minute. Basically borderline corneas, we can do this extra procedure where the dose given is 2.7 to 3.4 instead of the total 5.4. But PRK itself is a scarring procedure, so it is not proved to be effective. LASIK, you are doing C3R on the lower layers of the cornea, whereas we want to do cross-link on the upper layers, and therefore the only place where perhaps this is going to stay is Smile Extra. I'll skip this. Thank you very much.
Thank you, Dr. Vavikar.
And to speak on combined topography guided surface ablation with cross-linking. It's not working, is it? My talk is after him. I loaded it. You try. Huh?
Yeah.
Which one? HPMC.
अरे यार आपने इस पे कनेक्ट कर दिया था ना पहले ही देखो ना
Okay, in between it was not available. Yeah. Then correct. Yeah, okay. No, not much. You can't use Dexter nowadays.
while they are settling the technical glitches, if there are any questions, I think the faculty will be happy to take those questions right now. Any questions from the audience? Dr. Vavikar, there's a question for you. Sujata, would you like to take that question about safety of CXL in pregnancy?
I think there was a study by Narayan Netralia where they did a study of how much of UV light exposure a patient gets on CXL, and they found that I think several years you have to get exposed to CXL to actually have an effect on the body. So I think it should be safe, but because there is no specific study done, and I don't think it's possible to do it also, it's better to avoid it during pregnancy. Mainly for medico-legal issues.
Dr. Vavikar, you talked about oxygen supplementation. So when we are doing the patients, do you think giving like nasal oxygen or giving oxygen under the drape or anything, would that be of any benefit?
Oxygen has to be available on the corneal surface.
So how do you increase the oxygen supplementation?
So that one Avedro has come with a device where actually there is increase in the oxygen concentration on the surface.
It's a sort of goggles. It's a sort of goggles. They place on. Only thing we could keep the cornea area open and oxygen is supplied through the frame.
No, so that's what I'm saying. I mean, our normal oxygen that we give to the patient, say nasal oxygen.
No, it's not. It's not required. It's only in the cornea. It's on the corneal surface.
No,
There's a constant flow
I
of
understand.
oxygen.
I'm saying if you give it close to the eye, the nasal, the normal oxygen prongs, would that itself be of any benefit?
Yes, that's going to help because the cornea is going to absorb from the air, and since we are using a special specs which are supplying with the oxygen through a continuous supply on the top surface of cornea, so that's the cornea is absorbing more oxygen.
MC, that itself does cause
Yeah.
swelling. So I think using the BCL which we used to use earlier,
Yeah.
I think there's hardly any need now.
Yeah, there are different methods.
This is when the cornea is really thin, like sub 300, 250. That is the time all these things are required. For borderline cornea 300, 320, 350, you can wait, put hypoosmolar this riboflavin, wait for some time, maybe longer time, and then go ahead.
You said about the UV blocking contact lenses are where to get such contact lenses.
No, they are not required. We have to have a plain contact lens because they will block your UVA. If you put normally what we are getting, they are UV blocker contact lens. If you are going to use them, they are not. They will be useless.
Right. Thank you, Dr. Vinod Arora. We now take up the next talk about combining topography guided surface ablation with cross-linking. So basically, like Dr. Vavikar explained, cross-linking was a method, the conventional cross-linking was a method to strengthen the cornea and to prevent the further progression of keratoconus. But the problem here is, even after cross-linking, these patients very often have a very high cylinder, and with the amount of aberrations, and the quality of vision is very poor, and therefore these patients are not able to use normal glasses or even normal contact lenses, and not all patients are affording to go in for a scleral contact lens. So basically, combining a TPRK, that is a topo-guided PRK, with cross-linking really helps in smoothening the cornea so that these patients can be not only corrected of their aberrations, but also a fair amount of the cylindrical errors can also be corrected within the safety margin. So we first had the Cretan protocol, where what happened is the epithelium was removed by a topographic guided PTK at only a 50 micron level in a 6.5 to 7 millimeter optical zone, and this was followed by the corneal collagen cross-linking. We then had the Athens protocol by John Kanellopoulos, where the epithelium was removed by PTK, followed by a topographic guided ablation to correct the micro irregularities, and followed by the cross-linking. And then we had the group from Narayan Nethralaya, which did the study on manual epithelial removal, followed by a TCAT treatment with the Wavelight Allegretto platform, and that helped in smoothening the cornea with a maximum stromal ablation by the excimer laser of not more than 40 microns in the thinnest corneal region. So basically, who all can benefit from this procedure? Mild to moderate keratoconus, patients with thinnest pachymetry, which is more than 450 microns, patient with poor contact lens fits and were unhappy with glasses, patients with no active allergic eye disease or no active ocular inflammation, and no central scarring. So there are basically today, there are two planning stations which can be used for this, the Alcon Wavelight EX500 or the Schwind Amaris, and I'll be talking more about my cases on the Alcon Wavelight EX500. So I would like to present a few cases. This was the first case, a 28-year-old female with thinnest corneal thickness of about 518 microns with a grade 1 keratoconus. This was the pachymetry, the pentacam maps. As you can see, even the bad D was bad. And this is the pre-op topolizer scan, which is important to treat this patient on the Wavelight platform. So coming to the planning over here, what we need to understand here is, we first make the modified refraction on the wavelight platform to be 0. Having done that, we see what is the maximum ablation. So without any refractive correction, we are correcting about 11 microns in the central region just to smoothen off the aberrations of the topographic cornea. Again, the optical zone is kept between 6 to 6.5 millimeters depending on the position of the cone. The epithelial thickness is checked out from the AIOC and then is fed into this. And then we go to a Zernike's equalization where we try to match the C12 to the C4. Now here in this particular case, the amount of the Zernike spherical equivalent which we need to correct is a very small amount, and since we are not correcting the sphere in this case, it can be as good as negligible. So after C4, C12 combination, compensation, we are just modifying the refraction by a minus 0.16. Now, what is most important here is to check what is the residual Pachy before the ablation. So that is about 438 microns in this case. Now here, if you can see that the patient was accepting a cylinder of 3 and the topographic cylinder was 2.75. So we go with the 2.75. Most important thing is always treat, since we are doing a TPRK, that is a topo-guided PRK, always treat the axis as per the topolyzer. And now, again, here it's important to check what is the residual cornea after we would have ablated, because this is important because the type of riboflavin which you will use depends upon the residual stromal bed after the ablation. So here, since it is more than 400 microns, we can go with the isotonic riboflavin in HPMC. We have stopped using Dextran now. So this was the final treatment. We did an alcohol-assisted epithelial removal, went ahead with this treatment with the Dresden protocol. And this was a topolyzer scan after 1 month. So we can see that the cone is very well centralized even after 1 month. And this is the comparative map, as you can see, the pre-op and the post-op. And there is a change right at the 1 month stage in the steep K by about 2.5 diopters decrease. The astigmatism from 3.75 had come down to 1.5 diopters, and the best corrected visual acuity is same. So we're not losing any line in this particular case. In this second case, again, a grade 1 keratoconus with a thinnest point as 560. Again, this is a topolyzer scan. The planning remains the same. We check for the ablation. Now here we have gone with the patient's measured topographic cylinder was about 5.77, but then that would not give us enough residual stroma, and we can't go in more than 50 microns in the center. So as can be seen over here, the central ablation should not be more than 50 microns, and therefore we have gone with the patient's acceptance of 2.25. And this is the final correction. And again, the residual stromal bed is 458, so we go it with the isotonic solution. This is a 3-month scan. Again, here the steep K has decreased by 1.5 diopters. Astigmatism has decreased by 1 diopter, and the patient's refraction is improved from 618 to 69. A third case, again a 22-year-old male patient with a cylinder of minus 2.5 diopter, grade 1 keratoconus. These are the pre-op pentacam maps. This is the pre-op topolyzer maps. The planning again remains the same. I'm not going to go through the details again. Again, here we have gone as per the, in between the topographic cylinder and the patient's acceptance. We have gone a little over 50 microns, but again we had a good residual stromal bed, so we went ahead with this particular treatment. And this is a scan. This is a patient which is we have the scans for the longest time. This is a 1.5 years old scan, and here the steep K has decreased from 43 to 42.3. The change in astigmatism has come down by almost 2 diopters, and the best corrected visual acuity has come to 6.6. This is another one case where this patient had a combination of a sphere and a cylinder. He was improving only to 612. Grade 2 keratoconus. This is pentacam maps. The pre-op topolyzer scan. Now in this particular case, we checked for the residual ablation, and we are correcting only 17 microns with a 0 rule. And here there's a lot of difference between the patient's refraction and the topolyzer cylinder. Topolyzer cylinder is much lower than the patient's acceptance. So there could be a lens element in play, and therefore we are going in almost as close to the topographic cylinder, and therefore we're correcting about a 1 diopter cylinder in this particular case. Again, if you see here, the residual stromal bed would be only 390 microns, and therefore this is a case where we had to use a hypotonic riboflavin. So what, like Dr. Vavikar explained, what do we do if the cornea is thin? We can use a contact lens assisted treatment, or we can do a hypotonics, this thing, or we can use the Hafizi's protocols where we can change the amount of fluence in the time of irradiation for different corneal thicknesses. So this is a good chart which is published by Narayan Netralaya, where you can see the various thicknesses. So depending on what is your residual stromal bed, and depending on whether we are using a 3 millivolt or a 9 millivolt accelerated cross-linking, the amount of time for irradiance is defined. And they also have a nice calculator over here where we can keep changing the thickness, and we get to know the amount of time which is required for that particular case, for that particular thickness. So that particular patient where we used the hypotonic solution, so this was his map 6 months post-op. Again, his steep K had decreased, his astigmatism had decreased by almost 1 diopter, and the patient from 612 improved to 6.6. This is the last case, again a 22-year-old with a grade 1 keratoconus. Now in this particular case, we decided to use, and we are using more and more of this, of the streamlined procedure, that is the epithelial removal by a transepithelial removal. The advantage of this is the epithelial removal by the streamline takes into consideration the keratometry value, and therefore the removal of the epithelium is very regular. However, they don't have a link of the streamline with the TPRK. So therefore what we need to do is we need to feed this as 2 separate treatments. In the first treatment, we have just fed a small negligible sphere of 0.25, otherwise this would not go ahead. And we stop this treatment right when the epithelium is removed. So we don't allow that 0.25 to get treated. And having done that, we do a second planning for the TPRK as was explained before, with the same safety features. And this is the patient's 7 months post-op scans. Again, you see a significant improvement, centralization of the cone, and a great improvement in the best corrected visual acuity right from 6.15 to 6.6 partial, and uncorrected vision of 6 by 7.5. So what does this procedure add? Basically, it increases the corneal biomechanical stability. It flattens the apex of the cornea and also centralizes the cone in most cases. It helps in decreasing the mean spherical equivalent, and at the same time, it causes a regularization cornea, gives you a better quality of vision, and the most important thing is a better tolerability to normal soft contact lenses. Patients do not need to go in for the more expensive scleral contact lenses. I'm sure Dr. Quresh is going to be angry with me for having stated that. Thank you for your kind attention. I would now like to call Dr. Sujata Mohan, who is going to talk to us about the intracorneal rings and the procedure, the cares in cases of keratoconus which have gone beyond a particular limit. इसी में लोड किया है cares का.
Video is there, right?
Yeah.
Yeah, that one. Good afternoon. At the outset, I'd like to thank Dr. Nitin Balakrishnan for giving me this opportunity. I hope I'm audible. So my topic is on fighting the bulge with Intacs and cares. Intacs I've been doing for the past 14 years with excellent results, and recently we started using cares. So I'm going to share my experience. So the indications are patients who have inadequate vision with spectacles, intolerance to contact lens wear, patients with keratometric readings of greater than 52 diopters, stage 2 to 3 keratoconus based on amsalochromic classification, patients with clear central corneas, and cylinder of at least 4 to 4.5 diopters. So case 1 is a patient who is a 21-year-old male who had a corrected vision of 6.9 with 3.75 CIL. You can see on the topography, you can see the cylindrical error is about 5.93. So this is the pre-op pentacam. Pentacam also show a four-cylinder, and almost all the parameters are in red. This is an ASOCT just to make sure that there is no thickening of the epithelium. So this is a plan. So this plan, I have to thank Dr. Susan Jacob for giving me this plan. So this is what she has planned. She had planned was it's 4.6 to 7.1 millimeters. This is a zone that we are going to place the care segment. And the trifine size is 6.5 to 8 millimeters, the position between 4.5 to 8.5. And normally the depth of the cornea is half cornea plus 50 microns. So this was, in this case, was 300 microns. And the incision site was normally is around 180. You can plan, the incision is really dependent on how comfortable you are with inserting the segment, and you can plan at any area. So this is how the plan looks. And this is literally my first case, and I'm using a femtosecond laser from Alcon, but no financial interest. And after making the channels, you can use that Y spatula to just open out the channel a little bit. I like to mark the area where I'm going to put the segments, and the segment has been already prepared, and it's inserted into the area where I want the segments to go. You can make an alternative opening in the other area where you want this, if you want to pull it out. If you're not able to insert, in case of long segments, I'd like to make another opening here so that I can use a Sinskey hook to pull it out. But in this case, it was a slightly short segment, and we completed the case without using another opening. So this patient dropped cylinder from minus 3.5 to plus 1, and his uncorrected visual acuity improved to 612. And you can see the flattening is about 3.5 to 3.8. Most often we see that the spectacle cylinder may not coincide exactly with what you see on topography, but it's a comfort of the patient. The patient feels a lot more comfortable with uncorrected visual acuity. So this is a 1 month post-op of the same patient. And this is the pre-op, the comparison map at the end of 1 month. You can see a significant flattening. You can see the comparison map showing the amount of correction. At the end of 3 months, you can see a significantly more correction because we have added cross-linking as well, and the significant more flattening also is seen. And this is the ASOCT as well as slit lamp photo showing the case segment. And this is the Hoya trace refraction. I wanted the eye trace refraction. And the eye trace shows only a 1.62 cylinder, though the actual acceptance was a little bit more. And this is a 3 month post-op. Topographically, you can see there is a reduction from 5.93 to 4, but the patient accepted only about 1.25 sil. So this is again a power difference map showing only a 1.5 diopters of induced reduction, but the patient's comfort and the increase in the best corrected visual acuity as well as the spectacle cylinder also significantly showed a change. So case 2 is a 17-year-old male who had a 5-cylinder. Again, you can see the plan, what we have done. So we are going to insert the cone in the area of the segment in the area of the steepest area of the cone. And this is the pre-op and the post-op, and you can see the significant flattening, and the post-op showing a drop from -5 to -1.5 sil. So CARES works in 2 ways. It works as a volume replacement because the area of the cone is much thinner, and it sort of has a buttress on the area of the cone, so thereby preventing any further bulging of the cone. Also has an arc shortening effect which is similar to Intacs. The results are variable because there are no proper nomograms, no major side effects because we see quite a lot of side effects over a period of time in Intacs. But however, whatever procedure we do, it has to be combined with CXL. So coming to Intacs, Intacs are crescent-shaped PMMA rings which are inserted to the corneal stroma. Normally they are placed at 70% depth, and you can see that it has an arc shortening effect. So this is the normal cornea, and after Intacs you can see the amount of flattening it produces. The deeper you go, the more the flattening, and the thicker the segment you use, again the more the flattening. So in case of Intacs, you need to have a pre-surgical planning. So in addition to UCVA, BCVA, corneal topography, corneal pachymetry, we also need to know the pachymetry at the different locations, especially in the location where we're going to insert the Intacs ring. So this is a small video which shows how the Intacs is being done. It's not playing. Okay. So this is a patient who had a minus 4.5 with minus 7.5 SIL. So the total mean spherical equivalent is around minus 12. So here in intacs, you have to identify where you're going to make the incision. So you convert the minus 7.5 cylinder into a plus cylinder component. So you will get plus 12 with minus 12 with plus 7.5 cylinder at 115 degrees. So here at 125 degrees. So here we made an incision at 130 degrees looking at the posterior float as well. And we placed two segments because the mean spherical equivalent was higher. We placed a 0.5 SK segment superiorly as well as inferiorly. And this is a post-op showing an excellent response. You can see from minus 4.5 with minus 7.5, the patient dropped to minus 1 with 4.5. And it's almost half the mean spherical equivalent. This is again another patient who had a minus 2.25 with minus 4 SIL. And the planning here was using asymmetric segments. You can use a thinner segment or you can just put a single segment, especially if you have a very inferior cone. The incision is again on the steeper cylinder, steeper axis. It's marked at 130 degrees. And in this case, the mean spherical equivalent was only about 6.25, so we used only a single segment. So this is a pre-op and this is a post-op. You can see a significant reduction. In some patients, they do extremely well, and you can see that it's almost like a patient is able to see 6/9 even without glasses. So these are some of the other patients who had very good results. You can see the drop in cylinder, significant drop in cylinder. So we did a very small study when we started about 10 years back, and we found that the average reduction in cylinder post-intacs was about 3.75. Some of them showing much more significant reduction of even up to 7 or 8 diopters. Some of them showing very little response. So the advantage or comparison between intacs and CARES is intacs is a very standardized procedure. We can plan, there are nomograms. They are more rigid, but they're a little bit expensive, and results are more predictable in intacs, at least in my hands. In CARES, I think it still needs a little bit of fine-tuning. There are no nomograms. I've discussed with a lot of surgeons. Each of them do it in a different way, and each of them have their own optical zone. Some of them go very close to the center. Some of them go very far away. So there is no obvious nomogram. The only advantage is it's not expensive. The again important thing is it's a volume bidding procedure, and it's less rigid, more chance of tissue integration, tissue remodeling based on the endothelial pump and additional effect, and results are variable. Thank you. So I'd like to take the opportunity to announce the release of my color atlas today in Hall 1 at 6 o'clock along with the Specialties Award. I request all of you to please be there. Thank you.
How much axis of the posterior corneal curvature has effect on the choosing of the incision site?
How much is the axis, the posterior corneal curvature, does it influence your incision site? Yeah.
No, in the intacs. Not in CARES.
Excuse me.
Your screen is stretched. You need to make it. It's coming properly here. Anyway. After listening to, you have a question?
I have a question, Dr. Mohan.
Yeah, Dr. Ayush has a question for Dr. Sujata. There is a question.
See, there's a lot of noise that track is replacing the intacs and CARES. What is your view on it? Between track and the CARES and intacs, a lot of noise that this is slowly replacing that.
I personally feel, yes sir, we have adequate nomograms. CARES will definitely be a better procedure because we don't have any complications, intrusion, extrusion, and patient rubbing his eyes really doesn't bother. and also there is some amount of increase in the volume of the cornea. So it should replace, but the only downside is that we really don't know the effect. We cannot promise the patient something and then come with the results. Whereas intacts, I'm more confident. I know that at least 50% of the his mean spherical equivalent will go down, which I cannot promise with CARES. I think there are people like Rajesh Fogla is doing quite a lot of CARES. I think he should also give his opinion.
Ayush, you rightly pointed out there is a lot of noise. So as long as there is noise, we can wait for things to become clear. Sure. I'll be, after listening to all the presentations on cross-linking, the topo-guided PRK, the aurora intacts and stromal segments, we move on to DALK for keratoconus. I have no financial interest. I'll shorten my talk as well. Now, it's a general consensus that once you are not able to fit contact lenses, whether it's the rose scale lenses or the scleral lenses, and the patient is not able to tolerate, then you look at surgical options of restoring the corneal shape. Now, deep anterior lamellar keratoplasty refers to a surgical technique wherein you retain the healthy host endothelium and replace the pathological stroma with healthy donor tissue. The advantage is that you avoid endothelial rejection, so you get long-term survival of the graft, and because you don't use steroids for a long time, complications associated with steroids like glaucoma and cataract can be avoided. There are two main techniques, one where we try to expose the pre-decimus layer and the other one where you do the near decimus dissection. Exposure of the pre-decimus layer can be done by injection of air or viscoelastic, and the near decimus dissection you do layer by layer dissection. Preoperatively, you need to have some idea of the extent of the pathology, the regional pachymetry, and on anterior segment OCT, you see whether the pathology is involving the decimus membrane or is there any scarring of the pre-decimus layer. The big bubble technique was described by Mohammed Anwar back in 2001, and here you are using a 27 gauge needle to inject air into the stroma that creates a separation between the stroma and the pre-decimus layer. Earlier we thought it was the decimus membrane, and this, with the needle, it gives a success rate of about 65%. A type 1 bubble is when you get the bubble starts in the center, has a dense white frothy margin, and the separation is between the stroma and the pre-decimus layer. Type 2 bubble has a clear margin. It's a separation between the pre-decimus layer and the decimus membrane, and it can extend all the way to the limbus. Now you need a guarded depth refination, for which you can use a Hesburgh-Barron refine, or you can use a handheld guarded depth refine measuring 300-350 millimeters microns, or you can use the femtosecond laser, which gives you a shaped cut, so you can use a mushroom or you can use a zigzag. And in very large areas of ectasia, sometimes you may have to use a preset depth guarded diamond knife to make the groove. I prefer to do a debulking, after which I inject my air. Debulking helps deeper placement of the cannula, and once the bubble forms, it leads to faster deflation rather than spending time to debulk at that point of time. However, if the apex is very thin, you don't debulk the apex because then the air starts coming out anteriorly. Instead of the needle, there is a wide array of cannulas which are available, which are blunt tipped and have bottom port. They assist in formation of the big bubble much more easily. Now if you see here, after we have done the trephination and debulk, the air injection cannula is introduced, and as you inject air, you see the formation of the type 1 bubble. You can see it has a dense white frothy margin. As you inject air, it expands, reaching up to the margin of your trephination. You can do a sequential injection, whereas you initiate the bubble and then you do a paracentesis and then do the second injection. This is fairly repeatable once you are able to introduce the cannula up to the right plane. And if you select your cases where there is no abnormality affecting the pre-decimus layer, chances of complications are much less. In this case, you will see that we are using a viscoelastic to introduce what is called the visco bubble. So it works pretty much like the air, but here you use cohesive viscoelastic, and as you inject the viscoelastic, the air bubble in the anterior chamber gets displaced to the periphery. If you have an apical scar like this where injecting air can lead to undesirable effect, we do the partial thickness trephination, debulk. After we have debulked, we come to the periphery, make a peripheral pocket. This pocket is carried along the margin of the trephination. So this is basically a modification of Malbrand's peeling technique. So once you have done that dissection up to 85 to 90% depth, your left hand you have a tooth forceps And as you try to peel the stroma tissue away, the right hand you can have a blunt dissector just separating the fibers as they are separating. When you come to the thin apex, you have to be a little careful for the amount of pressure that you are applying, because if there is a pre-existing break like in hydrops, you can end up splitting the cornea at that point of time. This is a manual DALK. You can see that there is a very thin residual bed. So if your residual bed is less than 80 microns, you can get results which are as good as the big bubble technique. If you have access to intra-op OCT, you can use the OCT in real time to see the amount of residual left behind, and you can use that to plan your surgery, and even for the cannula placement, you can see what depth the cannula is placed. Post-operatively, one of the common complications that can happen, especially if you have had a microperforation, is a double anterior chamber. So intra-op, if you do get a perforation and you intend leaving an air bubble inside the anterior chamber, do perform an inferior surgical PI to prevent a pupillary block or a Ehlers-Danlos syndrome. In case you have perforation which involve the inferior quadrant, instead of air, you can use 20% SF6 for longer tamponade. So post-operatively, the eyes do very well. You can see good cell counts, which because the healthy host endothelium is retained. You don't use steroids for a pretty long period of time. Usually over a period of 4 to 6 months from full-strength steroids, we move on to softer steroid. Suture removal can be initiated. The interrupted sutures, you can start between 3 to 4 months. You can remove some sutures to manage the astigmatism. But the remaining sutures, we try to keep them as long as possible, at least for 1.5 to 2 years, unless they break earlier or they become loose. Femtosecond laser has an advantage that because of the better graft-host junction apposition, you can get good refractive outcomes. However, once all the sutures are removed, because the host cornea has inherent keratoconus, sometimes you can still end up with unpredictable astigmatism. Comparative study between decimatic and pre-decimatic, they have found that the visual outcomes are comparable, especially if you look at outcomes beyond 6 months. And so a lot of surgeons are saying, do you really need to inject air? They are going ahead and doing a manual DALK in most of their cases, going near decimus, trying to leave behind a very uniform interface and a residual bed of less than 80 microns. So in conclusion, DALK should be the procedure of choice for corneal transplant in keratoconus. Don't go back and do a penetrating keratoplasty. Surgical techniques are continuing to evolve to ensure more predictable outcomes, and the use of femtosecond laser technology and the intra-op OCT can definitely help improve outcomes in future. But even in your outpatient department, if a patient comes demanding DALK, saying that, I get that in my OPD, people come and say, I have keratoconus, I want DALK. I ask them, have you had a contact lens trial? They said, no. I said, then you first need to have a contact lens trial, because if you haven't used a contact lens, you don't even know what a contact lens can do for you. So a surgical intervention is always the last initiative. Just one point to make about topo-guided PRK, I was a good fan. I used to do them a lot, but I'm slowly moving away from any tissue removal procedures. I would rather look at tissue additive procedure. That means I would do stromal segments or put in segments where I can normalize the curvature better without sacrificing. Because I've burnt my fingers, Nitin has results showing 1.5, 2 years follow-up. I've seen these patients 4, 5 years down the lane, 7 years down the lane. They all go in for progressive hyperopia. They become +1, +2, and then the cornea starts becoming more flatter. I think it is because when you do cross-linking, sometimes the regenerative capacity of collagen is lost. So that's why you see this abnormal flattening, progressive flattening that you see. Since you cannot predict in a young patient who may otherwise not be very symptomatic, at least you would not want to do something for which you don't have a solution later on when he comes with the complication. Thank you for your patient hearing.
Thank you, Dr. Fogla. I now call upon Dr. Quresh Maskati. He'll be talking about how to visually rehabilitate all our keratoconus patients after having stabilized the progression with scleral contact lenses.
See how much flattening occurs, and then would you say doing C3R on contact lens would be a better option?
Well, like I said that we still don't understand what we are doing to the cornea. And since I did it for, not even for keratoconus, I did it for suspicious topography for where a laser procedure may have been contraindicated. I very confidently went ahead, did a refractive correction, patient became unaided 6/6. But the same patient at a follow-up later on in time comes, and young patient comes back with +1, with +1.5 cylinder. And then we don't have an option. What do we do to the patient? Patient is hyperopic and unhappy. And so that's why it's a good option. Maybe we need to discuss with the patient what are the things that can go wrong. And sequential is a great way to do it. If you want, maybe do a cross-linking first. Then I would do a topo-guided PRK. And then if there is any signs of further progression later on, I can think of doing a repeat cross-linking if required. But I would use the accelerated protocol for the same.
What I use only the abrasion part. I don't take cylindrical at all. So we just want to be conservative, want to preserve the tissue. Just we keep the reading 0, only, and that do on that.
No, what I meant to say is, see, C3R, how much flattening it's going to cause, we don't know.
Yes.
Along with that, if you're doing your, ablation also, in future, how is it going to impact?
So that's why we're not taking refractive part at all. We are just removing the ablation. That may be very minimal. Of course, it may change also after CXL.
In the interest of time, you can continue. I will continue simultaneously. So we're talking about scleral contact lenses. I have no financial interest. I used to get my scleral lenses, and whatever I learned from my scleral lenses over the last 20 odd years has been from Chandrasekhar Chavan. I now have a trial set from the LV Prasad, so my optom fits them, and then she orders the appropriate lens from there. Just want everyone to be on the same page when we're talking about scleral contact lenses. There are certain terminologies that we use. So there is something called the central vault zone, the peripheral corneal zone, the limbal lift zone, scleral landing zone, and the adjustment range. So this is what we normally, so that when you're talking to each other or you're discussing patients or ordering the lenses, these are some of the terminologies that we need to know. Also, we need to know what exactly do we mean by scleral lenses. So typically corneal lenses are those which rest, as the name suggests, on the cornea. Cornea scleral are, again, as the name suggests, resting on the cornea and sclera as well. In the scleral lenses, we have the mini sclerals. Many of our K-conus patients do well with mini sclerals, where the lens is up to 6 millimeters larger than the HVID. But the traditional scleral which you are looking at is about 18 millimeters or more, where the lens is more than 6 millimeters larger than the HVID. So the true scleral lenses, ideal diameter is about 18 millimeters. This is what we need to keep in mind. Just a little brief on the anatomy, so you know where approximately the scleral lens will sit. So we select the lens design trying to be as little technical as possible. If the cornea is smaller, 11.7 or smaller, then I typically use the mini sclerals of 16 mm. But for the larger corneas, 11.8 or more, I'll go for the regular scleral lenses. And we select the lens design based on the corneal shape. We know that the K-conus is prolate and hyperprolate as compared to the normal corneas. So if you have done a graft and you want to put a contact lens, then you can choose the oblate design, but otherwise you'd use the prolate design. So the diagnostic lens selection comes with prolate designs for normal corneas or mild K-conus. And for more advanced, you choose one with a deeper sag. And as I said, for post-graft cases, you'll choose the oblate design. Post-refractive surgery, you'll use the oblate designs. So there are 4 components to a successful lens fit. There should be a proper central vault, mid-peripheral adequate clearance, limbal clearance, and a scleral alignment. OCT comes in great use. When I started doing scleral lenses, we didn't have the OCT. Now we have the OCT. So it's sort of unthinkable to do a scleral lens fit without doing this, because you can then judge exactly how to. It's of great help in everything. And typically you should have a nice vault which is far away from the cone, from the cornea, from the irregular cornea. So it's useful not only in keratoconus, but I've used them for keratoglobus as well as for pellucids as well, and post-PKs as well. Nowadays you get this designer software by which you can make a 3D, like a 3D printing can be done to customize it for any eye. So these are some of the new things which are available to us. The software designed, the iPrint platform that we use. So just to summarize, you should consider scleral lenses both in your K-conus patients, as Rajesh correctly said. Before you jump into surgery, you should give them a good trial. I've used a lot of rose K lenses as well, but I've shifted almost entirely to the scleral lenses. I find they're more patient-friendly. And symptom-free, the patients are more symptom-free with the mini sclerals and the scleral lenses. And in the scleral lenses, depends on the sensitivity of your patient. Some of the patients have dry eye associated with the K-conus. In that case, you might encourage them to remove the lens even 2 or 3 times in a day and refill with saline and then put it on. It's not necessary that they have to wear it from morning to evening. But it cannot be that you are running a keratoconus practice without having scleral contact lenses in your armamentarium. So I thank you very much for your attention. Sorry? Yes, I do a lot of mini scleral lenses as well. So for the mild to moderate scleral patients, mini sclerals do fairly well. But if it's advanced a little bit, if there is a lot of irregularity, then I go for the full scleral lenses. I use scleral lenses for other indications also, so I'm quite comfortable with sclerals. For my Steven Johnsons and others, they are sometimes lifesavers. What we used to call the pros lenses, yeah. The piggyback lenses and the hybrid lenses, as I said, there are many ways to skin a cat. There is this, but I've used the piggyback lenses, I've used hybrid lenses, but now I find that with mini scleral and scleral, just these two, almost 100% of the patients can be fitted. So I don't experiment. I've tried and burnt my fingers in some patients with the piggyback. I've got some patients who are successfully wearing piggyback since many years. But if I get a new patient, I will not put him on piggyback or on hybrid. I'll put them straight on the mini sclerals and the sclerals.
What about the costing, Kuresh, of the scleral lenses? How expensive?
We do it with LV Prasad. So the costing is not all that great. I think it works out, with my profits, it works out about 50,000 for a lens. Yeah. 50 per eye. Which includes the profit my Optum makes. Thank you.
Thank you. Thank you. So if there are no questions from the audience, I think we'll conclude this session here. Thanks for having attended. And we hope to continue similar sessions in the next year also.